So what we've talked about so far is how the sympathetic nervous system allows for basically heart rate to increase. First of all, how the sympathetic nervous system allows for the sinoatrial node fibers to generate more frequent action potentials. We also talked about how the sympathetic nervous system causes conduction velocities throughout the AV node fibers to increase. So there's a shorter delay between when the atria and ventricles contract, and additionally how the conduction velocity increases through the conduction fibers so that the ventricular fibers can contract sooner with faster heart rates, higher heart rates. And the same is true probably for the conduction fibers that do exist, if they do exist throughout the atria as well. Now, collectively, that's a lot of different things. However, it really only translates into one thing, and that is heart rate increases with exercise. Now, that's half of cardiac output, right? Heart rate times stroke volume, how much blood can be pumped around the body per minute. Well, this is how we increase heart rate, but when we exercise, stroke volume also increases. So what we really want to do here is address how that happens, and it again comes back to the sympathetic nervous system. So here in this image, you can see that the sympathetic nervous system, we've already talked about this, right, travels out to ventricular fibers. It goes to both the contractile ventricular fibers and the conduction ventricular fibers, or conduction fibers of the ventricles, whatever you want to say. Now, all I told you so far is that it allows for the conduction velocity to increase throughout these fibers, particularly the conduction fibers is what's important there. What we didn't address is the other things that norepinephrine, as well as epinephrine circulating around the bloodstream, binding to these ventricular fibers does as well, which is increase the force of contraction. Epinephrine and norepinephrine doesn't just allow these conduction ventricular fibers to propagate faster action potentials, increase their conduction velocities. It also allows them to produce more force when they contract, and that's what we want to talk about here. This is the sort of generic picture that I show in 6116, and I don't get into a whole lot of detail here. We're going to go into a lot of detail talking about how this happens, okay? So, and I should say, a lot of this is theoretical too. So some of it is pretty definitive, and other components of this we're just not that sure about, and I'll address that as we go. Okay, so what do you see here? Well, clearly norepinephrine and epinephrine, what's being depicted here is they are binding to the plasma membrane of we're going to call this a ventricular contractile fiber. Okay, now this would be happening in the conduction fibers too, because components of this are actually what allow for the action potentials to propagate faster, increase the conduction velocity. But what we're talking about right now, which is how the fibers are going to contract more forcefully, this component isn't really important for the conduction fibers. The conduction fibers have the capacity to contract, and this happens to some degree within them, but the big thing that they do is propagate really fast action potentials. So what we want to address is the contractile ventricular fibers, and that's what I'm talking about here. Imagine this as being one of the contractile fibers within the left or right ventricle. What's happening is epinephrine or norepinephrine is binding to adrenergic receptors on this contractile ventricular fiber. And let's just remind you of the pathway that happens here, and then move on into some more detailed diagrams to really address these different things on beyond a basic level, which is what this image is doing. This image is very introductory. Now, what you can see pretty clearly here is that this adrenergic receptor is a cyclic AMP pathway. So epinephrine or norepinephrine binds to the adrenergic receptor, then the alpha subunit dissociates away from the beta and the gamma, activates adenylate cyclase, which starts converting ATP into cyclic AMP, and then cyclic AMP increases the activity of PKA, protein kinase A. All right, so you can imagine inside of the contractile ventricular fibers, when epinephrine or norepinephrine is binding to them during exercise, during the sympathetic response, protein kinase A is increasing within these fibers. And what we want to understand is how this increase in PKA, as well as other things too that we're about to talk about, could allow for these ventricular fibers to produce more force. So let's go with step one here. Phosphorylation of L-type calcium channels. Okay, that's being depicted in the previous image that we looked at, so we're going to take a look at it again. And we're going to talk about the consequences of this with regard to force of contraction, and also address the fact that this is probably what's allowing for faster propagation of action potentials within the different fibers as well. So here you can see pKa inside of this contractile ventricular fiber going over and phosphorylating L-type calcium channels. Okay, what that means is it probably opens up these L-type calcium channels. Let's say that it opens up more of them in the membrane than normal, or it somehow increases their open state. Either way, if you open up more of them or you increase their open state, what are you going to do? You're going to allow more calcium in. Okay, if you allow more calcium in, one, that's going to cause the action potential to propagate faster, right? Because you're going to have a greater influx of calcium because of the opening of these L-type, the opening of extra L-type calcium channels, voltage-gated calcium channels. And if you have more of them open throughout the membrane, the action potential will propagate faster, right? That's what allows ultimately the conduction fibers and these fibers to propagate their action potentials faster. Conduction fibers being more important. I just wanted to point that out, where it's coming from, because that's really not part of the conversation right now. What's the other thing that that's going to do with regard to increasing the force of contraction? Well, if you open up more L-type channels, L-type calcium channels, or you increase their open state and you allow more calcium in, right, through them, then there's going to be a greater quantity of calcium in the cytosol, in the intracellular fluid. And on the simplest level, if there's a greater concentration of calcium in the cytosol due to more of these L-type channels being open throughout the membrane, or increasing their open state, somehow making them even more permeable to calcium, something along those lines, that's going to mean that there's more calcium to bind to more troponin, and thus more myosin and actin will be able to interact. Because if more calcium binds to more troponin, then more tropomyosin will unwind off of actin, F-actin, and then more of the myosin heads will be able to interact with actin. Force is proportional to the amount of myosin heads bound to actin, so we'll get more force. So this is the first way by which more force can be generated within this cardiac contractile ventricular fiber if epinephrine or norepinephrine is binding to it. It allows more calcium to come in into the cell through the opening of more L-type channels throughout the membrane. More calcium inside of the cell means more troponin has calcium bound to it and more myosin interact. Now there's something else that's also very important about this that's actually not listed in that table that I just showed you, and that is if you allow more calcium in through these L-type channels, that means there's more calcium to cause calcium-induced calcium release. Basically, there's more calcium in the cytosol to bind to more of these ryanodine receptors located on the sarcoplasmic reticulum. So more ryanodine receptors in theory would open, and more calcium would spill out of the sarcoplasmic reticulum. And then this would be the second way by which there would be more calcium to bind to troponin and allow more myosin and actin to interact. So this effect that pKa has is actually twofold, right? What pKa does is straightforward, right? It opens up more L-type calcium channels, voltage-gated calcium channels in the membrane, allowing more calcium in to the ventricular contractile fiber. And hopefully this goes without saying, but right, these L-type calcium channels are opening, more of them are opening as the action potential is, propagating down the cardiac fiber itself, the ventricular fiber. So as an action potential propagates down a ventricular fiber, two things happen, right? The voltage-gated sodium channels open up and the L-type calcium channels open up. Okay, that's what happens as an action potential propagates down a ventricular fiber. or an atrial fiber for that matter, as long as it's not the SA node fibers. And the point is, as the action potential is propagating down the ventricular fiber, more of these L-type calcium channels are opening up than normal. Just in case you weren't clear on where these are coming from, that's it. All right, so more of these L-type voltage-gated calcium channels open up as the action potential is propagating down the ventricular fiber, allowing more calcium in. That's what pKa does. But two things. The more calcium coming in through the L-type voltage-gated calcium channels, that's more calcium that can bind to troponin, and more myosin and actin can interact. And the second thing is, if you bring in more calcium through the L-type channels, then more calcium can bind to the ryanodine receptors and cause greater calcium-induced calcium release, which also allows more calcium to bind to more troponin. So what pKa can do, we think it can phosphorylate the ryanodine receptor located on the sarcoplasmic reticulum inside of this ventricular contractile fiber. And if these ryanodine receptors get phosphorylated, one of two things, much like the L-type channels, either more of them can actually open up, or it can increase their open state, meaning simply that more calcium can travel through them than normal. What would that translate into? It would translate into more calcium being released from the sarcoplasmic reticulum under sympathetic stimulation within the ventricular fibers than normal. Why? Because norepinephrine or epinephrine binds to this ventricular fiber, to the adrenergic receptor. You follow it downstream, and you see that pKa phosphorylates the ryanodine receptors and essentially either opens more of them, which would allow more calcium out, or it increases their open state. And both of these two things would ultimately, if maybe it's a combination of both of them, would allow more calcium out of the sarcoplasmic reticulum, and thus, during calcium-induced calcium release, of course, and that would then allow for a greater release of calcium from the SR, which would allow more calcium to bind to troponin and more myosin and actin to interact. Now you might say, didn't the same thing happen in the last example? Yes, it did, which complicates our understanding of all of this, and partly why it requires a lot of technology, some of which we don't have, to try to figure out which of these is most important. Because isn't there, we just went over how more calcium coming in through the L-type channels can cause greater calcium-induced calcium release by binding to more ryanodine receptors than normal, than when not under sympathetic stimulation. So more calcium coming in through the L-type channels binds to the ryanodine receptors and opens more of them than normal. And pKa phosphorylating the ryanodine receptors may do the same thing as well. So of course the question becomes, well, what is more important? Is it the fact that more calcium is coming in through the L-type channels, and thus greater calcium coming in through the L-type channels is opening more ryanodine receptors than normal, or is it because pKa is phosphorylating the ryanodine receptors and that's causing more of them to open than normal? What I like to do usually in these situations is say, well, maybe it's a combination of both. But at the end of the day, what the most important thing that we know is that under sympathetic stimulation, regardless of what's actually driving it, ventricular fibers have greater calcium-induced calcium release. More calcium leaves their sarcoplasmic reticulums than normal, and that calcium then can bind to more troponin and more myosin can interact, and thus the ventricular fibers, the contractile ventricular fibers in particular, are able to produce more force. I'm actually going to skip this third one for the moment and come back to it in a second and describe the fourth example here, because the fourth is easy to explain, and the third one here requires us to delve into a bit of a more complicated conversation. So let's look at this fourth example, phosphorylation of troponin. It is very possible that protein kinase A inside of these ventricular contractile fibers is able to phosphorylate these troponin proteins. And if troponin gets phosphorylated, the idea is that it increases troponin's calcium sensitivity, basically making it easier for troponin to bind calcium, perhaps increasing its affinity for calcium or decreasing the number of calcium ions that it actually has to bind in order to become active. Okay, I think the simplest, broadest term that we could say is that, you know, phosphorylation of troponin by pKa increases its sensitivity for calcium. It makes it easier for calcium essentially to activate troponin. Okay, and if you do that, think about what that translates into. Okay, so under sympathetic stimulation, epinephrine and norepinephrine binds to adrenergic receptors on these ventricular contractile fibers, follow downstream, pKa levels increase, and they phosphorylate troponin, increasing troponin's calcium sensitivity, and thus making it easier essentially to activate troponin than normal. And that would translate into more tropomyosin unwinding off of F-actin and more myosin heads interacting with actin, and thus more force being produced. So this is yet another possibility by which the sympathetic nervous system is able to allow these ventricular fibers to produce more force. I have saved the most complicated ones for last. And this first complicated one is phosphorylation of phospholamban. It's really not that complicated, but it's kind of outside of the realm of anything that we've talked about in this course or in others. And that's why I'm saving it for the end, which is right now. So phospholamban is this protein that exists particularly in cardiac muscle fibers, contractile cardiac muscle fibers. And again, we're focusing on the ventricular ones in particular here, but phospholamban binds to the circupumps and it decreases their activity. Okay, basically it makes it harder for the circupumps to be able to pump calcium from the cytosol back into the sarcoplasmic reticulum. So we can say this: when phospholamban is active, the circupumps within the cardiac muscle fibers are less active, because what phospholamban is doing is it's binding to the circupumps and making them less active, and thus it's harder for the circupumps to actually pump calcium back into the sarcoplasmic reticulum. Now that doesn't mean that calcium is going to stay elevated inside of these cardiac muscle fibers. It just means that more of the calcium will get pumped back out into the interstitial fluid by different types of transporters, then calcium go back into the sarcoplasmic reticulum. This is one of the reasons that inside of cardiac muscle fibers, there's less calcium located within the sarcoplasmic reticulum, we believe. Phospholamban binds to these circupumps and decreases their activity so that less calcium moves from the cytosol back into the SR, and more of it actually gets kicked back out into the interstitial or extracellular fluid. All right, well, what can happen during exercise, though, or any sympathetic response? Well, epinephrine or norepinephrine can bind to adrenergic receptors, as you know, and epinephrine or norepinephrine binding to the adrenergic receptors, if you follow the pathway downstream, you're going to get an increase in pKa within the cardiac fiber, particularly within the ventricular contractile cardiac fiber. And what pKa can do is it can go over to phospholamban and phosphorylate it. And when phospholamban is phosphorylated, phospholamban is inactivated. Basically, phosphorylation of phospholamban by pKa knocks it out. What does that allow for? Okay, well, if pKa phosphorylates phospholamban and knocks it out, the job of phospholamban is to basically decrease the activity of the circupumps. So if phospholamban is less active because it's been phosphorylated by pKa, what that means then is that the circupumps are more active, and they're going to start pumping more calcium back into the sarcoplasmic reticulum than they normally would. Okay, so the way that you can say this in the simplest terms is that sympathetic stimulation of contractile cardiac fibers, particularly ventricular cardiac contractile fibers, sympathetic stimulation of them will increase the activity of their circupumps. Basically, these ventricular contractile cardiac fibers will be able to pump calcium back into their sarcoplasmic reticulums at greater rates under sympathetic stimulation compared to non-sympathetic stimulation. And that happens because pKa knocks out phospholamban, which makes the circuit pumps more active. Now, during a sympathetic response, we want to think about what would be the benefit of making the circuit pumps more active and thus allowing for the ventricular contractile cardiac fibers to be able to pump more calcium back into the sarcoplasmic reticulums than normal. One, the fiber will relax faster. Okay, if the circuit pumps are more active, they'll be able to pump more calcium back into the sarcoplasmic reticulum faster. This doesn't explain how more force is being produced within the contractile cardiac fiber, but I do want to point this out. If the circuit pumps are more active, because phospholamban has been inhibited by pKa, phosphorylating it, then what that translates into is calcium being pumped back into the sarcoplasmic reticulum at faster rates, and thus these contractile ventricular fibers relax faster because the calcium that gets released for contraction also gets pumped back into the sarcoplasmic reticulum faster, and the pumps that pump the calcium back out into the interstitial fluid also work faster. And what that translates into is a greater rate of relaxation. The contractile cardiac fiber is able to relax faster under sympathetic stimulation than it is under non-sympathetic stimulation. And something also that we think activates the circuit pumps is elevated calcium levels inside of these contractile fibers. Basically, we think that calcium can bind to the circuit pumps and increase their activity as well. And you already know during sympathetic stimulation, there's a lot more calcium in the cytosol within the cardiac contractile fiber, this ventricular cardiac contractile fiber, than normal. So that's more calcium binding to the circuit pumps, making them more active. pKa is also phosphorylating and knocking out phospholamban. Both of these things make the circuit pumps more active, so more calcium can be pumped back into the sarcoplasmic reticulum at faster rates, and the fibers can relax faster. This, for one, is really important when heart rate is really high. Okay? If there's a high heart rate, like what happens during exercise, right? Heart rate increases pretty significantly. If contractions are happening at a high frequency, you also need relaxation to happen faster. You want the cardiac fibers, again, particularly the ventricular contractile fibers, to produce more force, but you also want them to relax faster when heart rates are very high. And that's exactly what happens here. However, that part doesn't explain how more force can be produced from this. It just explains that the cardiac fibers can relax faster during sympathetic stimulation because they can pump more calcium back into their back into their sarcoplasmic reticulums because of increased activity of their circuit pumps. Now, what explains the increased force of contraction from this pathway? Okay, this pathway doesn't just allow for the cardiac fibers to relax faster, it also allows for the cardiac fibers to produce more force. How could that be? Well, let's think through this. If phospholamban has been phosphorylated and thus knocked out, and the circuit pumps are more active, pumping more calcium back into the sarcoplasmic reticulum than normal, that means during sympathetic stimulation, particularly ventricular contractile cardiac fibers have more calcium in their sarcoplasmic reticulums than they do in non-sympathetic situations. How could that be the case? Well, because during sympathetic stimulation of these ventricular contractile cardiac fibers, their circuit pumps are more active and they're pumping more calcium back into their sarcoplasmic reticulums than they normally are, and thus the overall calcium concentrations in the sarcoplasmic reticulums within these ventricular cardiac contractile fibers is higher. And that means there's more calcium to release from the sarcoplasmic reticulum, right? If these cardiac fibers, these ventricular contractile cardiac fibers, have more calcium within their sarcoplasmic reticulums, that's more calcium to release through the ryanodine receptors during contractions, so that more calcium can bind to troponin and allow more myosin and actin to interact, right? And more force can be produced. What we think happens is during exercise, due to this pathway from the sympathetic nervous system, ventricular fibers actually have more calcium in their sarcoplasmic reticulums due to more active circopumps. And thus, those same ventricular contractile cardiac fibers are able to now release more calcium from their sarcoplasmic reticulums, from calcium-induced calcium release. And by consequence, that's even more calcium that can bind to troponin and more myosin and actin can interact. So this is yet another explanation, possibly, by which the sympathetic nervous system is able to increase intracellular calcium so that the ventricular contractile cardiac fibers can produce more force. Think about all the things that we said. The sympathetic nervous system allows more calcium in through L-type channels. The sympathetic nervous system opens up more ryanodine receptors to allow more calcium out of the sarcoplasmic reticulum. The sympathetic nervous system allows more calcium into the sarcoplasmic reticulum to be released from the sarcoplasmic reticulum. All of those are causing greater intracellular calcium levels during contraction of these fibers and thus allowing for more force to be produced. Not to mention, the system can possibly phosphorylate troponin and make troponin even more sensitive to calcium than it normally is. Perhaps you can really begin to see here why all of these different explanations are so complicated and hard to understand, because they all kind of overlap with each other. So trying to tweeze out which is the most important and which is actually happening, right? It's very, very hard to do, especially with the technology that we still don't have to this day. We know some of these things are happening, but which of them is the most important, or the degrees to which they're happening compared to others, is like, it's very hard to understand. Regardless of that fact, you have seen the possibility, plus more possibilities, as to how the sympathetic nervous system allows for these ventricular contractile cardiac fibers to produce more force under sympathetic stimulation under exercise. This last one over here is really the same as the first. It's just saying that the alpha subunit may be able to open the L-type channels as well. That one I won't ask questions about because it's the same thing as the first one. All of these are potential explanations, and many of these are probably all happening simultaneously, actually, to allow for the ventricular fibers, particularly the contractile ventricular fibers, to produce more force. Now, there's actually one other explanation for this, one more theory, I should say, that's related to the sympathetic nervous system as well, but in many ways is also its own unique pathway. So let's talk about that. That's the last one, and I would again also say it's one of the more confusing ones, so I have saved it for the end. All right, I don't think I need to relitigate the fact that under sympathetic stimulation, if you look inside of a ventricular contractile fiber, a ventricular contractile cardiac fiber, under sympathetic stimulation, there's going to be a greater amount of calcium within the cytosol during contraction. Now, there's something else that increase in calcium would do. This increase in calcium, we know also within the fiber, binds to Calmodulin. Calcium, this increase in calcium, some of the calcium ions will bind with Calmodulin and form the calcium-Calmodulin complex. And then what calcium-Calmodulin will do is it will actually activate what's called myosin light chain kinase inside of the ventricular contractile cardiac fiber. And what does MLCK do? Myosin light chain kinase, you've actually seen this before, but explained slightly differently. Myosin light chain kinase, we think, can go over and phosphorylate the light chains within the myosin heads, which actually, as you've seen in the past with skeletal muscle, can do potentially a variety of different things. But let's first remember how we got here. Okay, under sympathetic stimulation, within this ventricular contractile cardiac fiber, there is a greater quantity of calcium within the cytosol during the contraction than normal. Some of that calcium is binding with calmodulin, forming a calcium-calmodulin complex, which is activating myosin light chain kinase, which is then translating into phosphorylation of the regulatory light chains or myosin head light chains. And what could that be doing? Well, rather than going back through all of the possible other explanations that we mentioned with skeletal muscle, I'll just give you this one to save your sanity, hopefully, a little bit. Here you can see the myosin heads in a non-phosphorylated situation. When the regulatory light chains have not been phosphorylated within the myosin heads, they lie more parallel to actin. Okay, now the fiber is under sympathetic stimulation. Okay, norepinephrine's binding to the adrenergic receptor, which is translating in, if you follow the pathway down, to many different explanations as to how more calcium is increasing within the fiber, allowing potentially more force to be produced that just simply because more calcium is within the fiber than normal. But also the calcium is binding to calmodulin, which is activating myosin light chain kinase, which is then phosphorylating the light chains within the myosin heads, and that changes the myosin heads so that they lie more perpendicular to actin. And if the myosin heads are lying more perpendicular to actin, it increases the probability that the myosin heads will interact with actin, and this will also allow for more force to be produced within these ventricular contractile cardiac fibers. Said more simply, the sympathetic nervous system is causing this, kind of indirectly, also directly, however you want to say it, by increasing the amount of calcium inside. But again, it's also sort of a separate pathway. We know this happens during exercise, and we know that it's related to the sympathetic nervous system. At the end of the day, again though, it's just another mechanism by which contractile cardiac fibers, again particularly within the ventricles, can produce more force. The light chains within the myosin heads can be phosphorylated, and that can change their orientation to actin and increase the probability that the myosin heads will interact with actin, and that will allow for more force to be produced. I have now given you a very long list of different possible explanations as to how ventricular fibers produce more force during exercise from the sympathetic nervous system, sympathetic stimulation. Okay. Now, if the ventricular fibers can produce more force through a combination probably of many of those different pathways, what does that ultimately mean? If the ventricular fibers can produce more force, then they can pump more blood out with each beat. What is that? Stroke volume. Okay, so what actually happens during exercise due to the sympathetic nervous system? Heart rate increases. We know this, right? The heart beats more frequently, mostly due to sympathetic stimulation of these sinoatrial node fibers, causing them to generate more frequent action potentials. There are many other things that help the components of an increased heart rate, like a decreased PR segment and greater conduction velocity throughout the conduction fibers as well. But the big thing about increasing heart rate is stimulation of the sinoatrial node. Okay, what's the other thing that happens? Stroke volume increases during exercise. Norepinephrine and epinephrine bind to ventricular contractile cardiac fibers and allow them to produce more force through a combination probably of many, many different mechanisms. And if they can produce more force, the ventricular fibers, then more blood can be pumped out of the ventricles, particularly the left ventricle, with each beat. And that means an increased stroke volume. So the sympathetic nervous system is going to increase the frequency of contractions. It's going to increase heart rate. And it's also going to increase how much blood the left ventricle can pump out with each beat by allowing the ventricular fibers to produce more force. So both heart rate and stroke volume, which equals cardiac output, how much blood can pump around the body per minute, increase during exercise. So what does this tell us about cardiac output during exercise? How much blood pumps around the body per minute, right? It substantially increases. It can go from like 5 liters of blood circulating around the body per minute at rest to like 25 liters of blood circulating around the body during exercise. Cardiac output significantly increases during exercise due to increases in both heart rate and stroke volume from the sympathetic nervous system. The heart is beating more frequently and it's pumping more blood out with each beat, which means a big increase in cardiac output. Now, all I've done so far is shown you the sympathetic nervous system, and there are more explanations for what increases stroke volume during exercise than just the sympathetic nervous system. So what also happens when we exercise is more blood is returned to the heart. There's a greater increase in what's called venous return. How much blood is coming back to the right atrium and consequently all of the chambers of the heart during exercise. How does this happen? One, because when we exercise, our skeletal muscles are contracting more, squeezing the veins and thus pushing more blood up towards the, and I'm talking of course in the lower extremities here, up towards the right side of the heart. Okay, so because skeletal muscle contracts more frequently during exercise and more forcefully, more blood is being squeezed within the veins and thus being pushed back towards the heart. More blood is being pushed back towards the heart during exercise than at rest. At rest, the skeletal muscles aren't contracting as frequently, they aren't contracting as forcefully, and thus less blood at rest is being pushed back towards the heart from the lower extremities. So the other thing that happens when we exercise, besides our skeletal muscles contracting more frequently and forcefully and squeezing veins and pushing more blood back towards the heart, the other thing that we do is we breathe more frequently. When we breathe more frequently, not only do we breathe more frequently, but we breathe more forcefully when we exercise. Okay? What that does is it also helps push more blood back towards the heart. How that happens is by manipulating what we call intrathoracic and intra-abdominal pressure. Okay? When we inhale, the chest wall expands, and that causes intrathoracic pressure, basically pressure within the thoracic cavity, we better go over here to inhale, right? When we inhale, the chest wall expands. Okay? The thoracic cavity expands and intrathoracic pressure decreases. But if you look in the abdomen, the opposite happens. Intra-abdominal pressure increases. And when you increase intra-abdominal pressure, what happens is the veins within the abdomen get squeezed, and thus more blood within the veins gets pushed towards the heart. Okay, and then when we exhale, the whole opposite of that process occurs. When we exhale, the chest wall collapses or it recoils. Okay, that's going to cause two things to happen. When we exhale, the chest wall collapses or recoils, and that drives up intrathoracic pressure, but it decreases intra-abdominal pressure. Okay, so when we exhale within the abdominal cavity, we get a decrease in intra-abdominal pressure, and of course that doesn't translate into veins being squeezed and blood being pushed back towards the heart. But what we have to focus on, though, is when we exhale, the chest wall collapses or recoils. And as the chest wall collapses or recoils, that drives up intrathoracic pressure when we're exhaling, and that squeezes veins within the thoracic cavity when we're exhaling, and that also then is going to push more blood back towards the heart. It's going to increase venous return. Okay, so the more frequently and forcefully you breathe, the more blood you're going to return to the heart through this respiratory pump. Every single time you take a breath in and a breath out, more blood gets returned to your heart. During exercise, we know that we breathe more frequently and more forcefully, so that's going to exaggerate this effect, right? If during exercise we breathe more frequently and forcefully, we're going to return more blood to the heart through what's called the respiratory pump, this process of returning more blood to the heart when we inhale and exhale. That's going to happen to a much greater degree during exercise because we're doing this more frequently. So collectively, we could say venous return, how much blood is being brought back towards the heart. Venous return increases. The amount of blood we're bringing back towards the heart increases during exercise, really for two reasons. Because there's more reasons than this too, but because skeletal muscles are contracting more frequently and forcefully squeezing veins, bringing more blood back towards the heart from the lower extremities in particular. Additionally, during exercise, we increase our frequency and our force of breathing, right? The frequency by which we breathe is higher. The force of contraction while we're breathing is higher. That means more blood is also going to return to the heart during exercise because of basically an increased respiratory pump as well. Now, what does more blood returning to the heart during exercise mean for the heart chambers? It means that during exercise, more blood returns to the heart than normal. Right? During exercise, there's more blood being returned to the heart than normal. Venous return is higher, and thus the chambers during exercise are filling with more blood than they normally are. What we would say is their end diastolic volume increases. End diastolic volume for the right atrium, the right ventricle, the left atrium, the left ventricle, it all increases. Every single chamber has an increased end diastolic volume. How much blood is within that chamber at the end of diastole, at the end of relaxation. End diastolic volume increases in all of the chambers during exercise due to an increased venous return, more blood coming back to the heart. And that causes each chamber to stretch more, right? Because more blood is filling within these chambers, and if more blood is filling within the chambers, then the chambers are stretching more. The increased amount of blood within the chamber at the end of relaxation, at the end of diastole, is causing the chamber to stretch more. And we know that when heart chambers are stretched more, the cardiac fibers, particularly the contractile fibers that make up those chambers, they produce more force. Basically, when you stretch any cardiac fiber, again, but particularly the contractile ones, when you stretch them more, they produce more force. We've known this for 100 years. Actually, well more than 100 years. But there's long been the question of why, when you stretch a chamber more, and thus you stretch the cardiac fibers, the contractile fibers that make up that chamber more, why do those contractile cardiac fibers, why do they produce more force when they're stretched? Because, if they produce more force, you're going to get an increase in stroke volume too. Basically, I mean, we can come to the end conclusion of this because that's not the hard part. You've seen this in 6116. I'm going to show you something completely different. If the left ventricle fills with more blood during exercise, which it absolutely does, there's a point of diminishing return in most people besides really elite athletes as exercise intensity gets really high. But generally speaking, the left ventricle fills with a lot more blood during exercise due to increased venous return than at rest. And the left ventricle stretches more, and the left ventricular contractile fibers stretch more, and they produce more force, and that causes an increase in stroke volume. How much blood can be pumped out of the left ventricle with each beat? That's combined with sympathetic stimulation of those fibers. But the real question has always been, what about stretching cardiac fibers causes them to produce more force? And we now know quite confidently, I shouldn't say quite confidently, but pretty confidently, that the old sort of Frank Starling mechanism it's just probably inaccurate. The old belief was if you looked inside of a cardiac muscle fiber, you would find that the sarcomeres within that cardiac muscle fiber were overly shortened. Okay, basically, if you look inside of a cardiac muscle fibers are filled with myofibrils, just like skeletal muscle fibers are. Those myofibrils are made up of repeating segments of sarcomeres. Okay, we're looking at one sarcomere here within this cardiac muscle fiber. And the belief was kind of at rest when heart rate is like 70 beats per minute. It was that the sarcomeres within the cardiac fibers were overly shortened, and that created double overlap of actin. Basically, the actin filaments cross to the end line, and went into the adjacent part of the sarcomere, and that wherever there was double overlap of actin, in that region called the double overlap region, myosin and actin were not able to interact. Okay, so this was the historical belief that, again, cardiac fibers, particularly the contractile ones, have overly shortened sarcomeres. So shortened, actually, that the actin filaments cross the M line into the adjacent portion of the sarcomere, and there's double overlap of the actin filaments, and that prevents myosin and actin in those regions from being able to interact, and thus force can't be produced in that central region. So sarcomeres at rest, and at rest I mean like 70 beats per minute, they produce submaximal force. Right, because the whole central region of each sarcomere can't, the myosin and actin can't interact in that region, and force can't be produced. So if you take a chamber and you fill it with more blood, like we get during exercise due to increased venous return, the chamber will stretch more, and the cardiac fibers that make up that chamber will stretch more, and thus the sarcomeres within those fibers will stretch more. Okay, so what you're seeing here at the top is you're seeing this is that same sarcomere within that cardiac fiber, but now that sarcomere is being stretched. It's being stretched because the fiber itself is being stretched, because more blood is, filling within the heart, causing the chamber to stretch more. And when you stretch that fiber out, you stretch the sarcomeres out, and you remove that double overlap of actin in the center. If that double overlap region is removed, now myosin and actin within these regions can interact again, and the sarcomere can produce maximal force. This was and still is, much of the time, the believed mechanism by which increased end diastolic volume, increased stretching of a chamber, allows the fibers that make up that chamber to produce more force. Because stretching of the chamber, and thus the fibers that make up the chamber, stretched out the sarcomeres within those particular fibers, and that removed the double overlap within the sarcomeres and allowed more myosin and actin to interact, and thus more force was produced, because force is proportional to the amount of myosin and actin interacting. And this was the explanation for how greater end diastolic volume caused a greater stroke volume. Another way of saying how a greater amount of venous return, how more venous return during exercise allowed for the cardiac muscle fibers to produce more force. In recent years, this has appeared more and more and more to just look inaccurate. There's not really strong evidence anymore that cardiac sarcomeres, meaning sarcomeres within cardiac muscle fibers, are overly shortened. It doesn't look like this sort of double overlap of actin really happens within cardiac muscle fibers. Many medical physiology texts have gone as far to say, even at this point, that this whole idea is just false. There's a decent amount of consensus within the cardiac scientific community that this Frank Starling overly shortened sarcomere theory is just wrong. Now, that doesn't mean that when you stretch a cardiac fiber more that it doesn't produce more force, because it absolutely does. If you stretch a cardiac fiber more, the more that it's stretched, there's a degree of diminishing, there's a point of diminishing returns here too, but generally speaking, the more that you stretch a cardiac fiber, the more force it produces. So the overall observation is not inaccurate. That hasn't changed. It's the theory trying to explain why a stretched cardiac fiber is able to produce more force that has changed. So what are the other explanations as to why cardiac fibers produce more force when they're stretched? These are incredibly poor. The theories behind them, nobody really knows, I would say. I'm going to give you a couple possibilities, but it's so hard to know for reasons we'll talk about in a second. All that seems to be relatively clear is that cardiac sarcomeres at rest, again, when the heart rate is like 70 beats per minute, they're probably not overly short. So at least this theory can't be accurate, but that doesn't mean that we actually have an accurate theory to kind of take its place. Let me expand on this, and then we'll go from there. The two major things that you'll hear is when you, let's pretend that this is a cardiac muscle fiber, when you stretch the cardiac muscle fiber more, what's possible is that stretching of the cardiac fiber, exactly how this happens isn't completely clear, but if you take the cardiac fiber and you stretch it, that possibly increases the calcium sensitivity. So basically, perhaps troponin, for whatever reason, is more sensitive to calcium when the fiber is stretched more. That would mean within that stretched cardiac muscle fiber, you have troponin that's more sensitive to calcium and thus can bind more calcium or doesn't need to bind as much calcium, and thus more myosin and actin can interact and more force can be produced. Okay, that's one possibility, although again the evidence for it isn't all that strong either. Another possibility is that, and I think this one has some, this and the next one both theoretically make the most amount of sense, although again they're not proven either. So if you take a cardiac fiber and you stretch it out more, it changes the shape of the cardiac fiber from obviously being more spherical to sort of, more of a cylinder, rectangular shape. And what that might do is it might actually change the orientation of the myosin and actin filaments and increase the statistical chances that myosin and actin interact. Basically, similar to some of the other things that we've discussed, although this wouldn't be through phosphorylation. If you take a cardiac fiber and you stretch it out, you're, in essence, you're putting myosin and actin closer together. Okay? And if myosin and actin, the filaments, are closer together, you're increasing the statistical chance that myosin and actin will be able to interact, and thus more myosin and actin will interact and you'll get more force. And this actually makes sense. Like, if there are definitely some downfalls to this theory too, but if you were to take a fiber that is more, let's say, spherical shaped, it's balled up kind of, basically the actin and myosin filaments would be in essence further apart from one another. Okay, there'd be basically greater space that existed between the filaments. And if you were to take the fiber and stretch it out into, again, more of a cylinder, a rectangular shape, these two filaments would actually move closer together, and more myosin and actin would be able to interact and more force would be produced. Another possibility is that there are calcium channels embedded in the plasma membrane of cardiac muscle fibers that are stretch sensitive. So if you take the cardiac fiber and you stretch it out, perhaps there are stretch sensitive calcium channels embedded in the plasma membrane that open. So these stretch sensitive calcium channels open up in the plasma membrane, because if you take the fiber and you stretch it out, that's going to have a direct effect on the plasma membrane of the cardiac fiber. Okay, and basically these calcium channels would sense that deformation and open, and that would allow for a greater influx of calcium ions into the fiber and allow for more calcium to interact with troponin and more myosin and actin, thus to interact and more force to be produced. These are all kind of a combination of three different going theories as to how, when cardiac muscle fibers, again, particularly the contractile cardiac muscle fibers, because that's the kind that we're interested in right now, and really the only relevant ones for this conversation. That's a couple of, three different possibilities as to how those fibers are able to produce more force when they're stretched. Again, there's pretty strong consensus around the fact that it doesn't have anything to do with the fact that double overlap in the center of the overly shortened sarcomeres is removed. It's definitely more likely that it's one or a combination of these three different things, although probably other explanations will pop up in the next 5 to 10 years. Anyways, let's continue on and finish this. So here's what we know, and we've known for a long time. Heart rate increases during exercise. The heart beats more frequently. Also, the heart pumps more blood out, particularly the left ventricle, with each beat. We've known this for well over 100 years. The heart beats more frequently during exercise, and the left ventricle pumps more blood out, called stroke volume, with each beat. Those two things mean cardiac output, how much blood is pumping around the body per minute, increases. How much blood is pumping around the body per minute is going to be dictated by how frequently the heart is beating, heart rate, and how much blood is being pumped out with each beat, stroke volume. Both those increase. Now, what causes heart rate to increase is easy, right? At least compared to stroke volume, right? What causes the heart to beat more frequently is manipulation of the sinoatrial node by the sympathetic nervous system. The sinoatrial node generates more frequent action potentials. And if the SA node generates more frequent action potentials, then the frequency of heart contractions increases. Heart rate increases. Now, what causes stroke volume to increase? Like, what causes particularly the left ventricle to be able to pump more blood out with each beat? Well, for that to happen, the left ventricle, the cardiac muscle fibers that make up the left ventricle have to be producing more force. Okay, we've known that for a really long time too. If you want the left ventricle to pump more blood out with each beat, you need the cardiac muscle fibers that make up the left ventricle to contract more forcefully. Now, that's partly accomplished through the sympathetic nervous system, through norepinephrine and epinephrine binding to those ventricular contractile cardiac fibers, causing them to produce more force. And it's partly because of those ventricular contractile cardiac fibers stretching more. We know that during exercise, more blood is returned to the heart. There's an increased venous return, and thus more blood fills within the chambers of the heart. So the end diastolic volume of the left ventricle increases. How much blood is in the left ventricle increases, and thus how stretched the left ventricle and the left ventricular cardiac contractile fibers are stretched increases. That also causes, combined with the sympathetic nervous system, these left ventricular contractile fibers to produce more force and thus cause stroke volume to increase. The really complicated question is how the sympathetic nervous system and stretching of these left ventricular contractile cardiac fibers allows them to produce more force. That is what is so incredibly sophisticated and complex. We have ideas as to how the sympathetic nervous system and stretching of these fibers allows them to produce more force, but the actual true mechanisms by which this is being driven are just not completely clear and will continue to not be completely clear, I think, for a very, very long time. Research regarding how these ventricular cardiac contractile fibers produce more force will continue on for decades. So let's spend a little bit of time now talking about what are called the calcium channel blockers. Really commonly used drugs for different cardiovascular diseases. What you're looking at here is a type of calcium channel blocker called Diltiazem. Diltiazem is used to treat everything from there are things that it's used more for than others, but it's used to treat high blood pressure, it's used to treat angina, it's used to treat heart arrhythmias. And it does this all, again, to different degrees, by targeting L-type calcium channels. It's called a calcium channel blocker. Right? It's also used, as you'll see, it's used for targeting smooth muscle within vessels too. I'm not going to talk about that right now. But it can assist significantly with, let's say, angina, which is chest pain, usually due to a blocked coronary artery, by blocking L-type calcium channels. and it can help with heart arrhythmias, it can help with blood pressure, all of those things by just going after those L-type channels. And we could spend hours talking about this. But let's just focus, for example, on how it could, since we've been talking about the heart so much, how it could help with angina. And realize that there are all sorts of different classes of calcium channel blockers for the heart, and they're really all targeting calcium channels, typically voltage-gated calcium channels. That's what they're going after, trying to block them. So how would this help angina? Angina is chest pain. Not everybody has this, but a decent number of people with atherosclerosis do experience angina. Okay, so if you have atherosclerosis, you have basically, to some degree, blocked coronary arteries due to plaque buildup, and insufficient quantities of oxygen are getting, and I guess I have to change the color here, are getting to the heart muscle, okay, cardiac muscle fibers. Okay, oxygenated blood is brought to cardiac muscle fibers by the coronary arteries. And if inside of the coronary arteries over here there's a bunch of plaque, this is showing a blood clot, but that would be a full-blown heart attack. That's not what we're talking about right now. But if there is plaque, there's going to be reduced blood flow through these coronary arteries, and there's going to be reduced blood flow to then the cardiac muscle fibers, in this example particularly of the left ventricle, which is bad news. If insufficient quantities of blood are going to the left ventricle, then the left ventricle is receiving insufficient quantities of oxygen. The left ventricular fibers, in this example, need that blood and thus oxygen within the blood in order to be able to make ATP and meet their ATP demands and not die. Cardiac muscle doesn't regenerate, not good. So if someone experiences a strong bout of angina, chest pain, oftentimes this happens when, they're outside shoveling snow in Florida, maybe digging a hole in their garden, or, doing some moderate, vigorous physical activity. It doesn't have to be, but doing some moderate activity where there's an increased oxygen demand from the cardiac muscle fibers, right? During that activity, when the cardiac muscle fibers have a higher oxygen demand, they should be receiving more blood and thus receiving more oxygen to make more ATP to meet their ATP demands. But if that person has a decent amount of atherosclerosis within their coronary arteries, then that person's not going to be able to actually bring a sufficient amount of blood to, and thus oxygen, to those cardiac muscle fibers, and they won't receive enough oxygen, and that will translate into, we believe, chest pain called angina. Now, diltiazem can be used in these situations to help alleviate some of this angina, and that's accomplished by blocking the L-type calcium channels. How would that happen? Explanation is actually quite easy. If diltiazem binds to and knocks out some of these L-type calcium channels, I'm not saying it does it to all of them. If it did it to all of them, the person would be dead. Okay, so the idea is diltiazem blocks some of these calcium channels. What we're looking at here is a ventricular, right, cardiac muscle fiber. You have to pretend. This is a ventricular contractile cardiac muscle fiber, and diltiazem is blocking some of its L-type calcium channels, and they can't open. Okay, if these L-type calcium channels, some of them, not all of them, but if some of them can't open, or they can open to lesser degrees, okay, a lot of these drugs we don't even fully understand how they work, we just know that they do. If it blocks these channels to some degree and prevents some of them from being able to open, there's going to be less calcium that comes in, clearly, right? Intracellular calcium levels within these ventricular contractile cardiac fibers will fall because L-type calcium channels within the plasma membrane aren't opening due to diltiazem. All right, well, what does that mean? If there's less calcium within this fiber, there will be less calcium-induced calcium release. So what does all of that mean? It means there will be less calcium to bind to troponin and less myosin and actin will interact with each other. What will happen? The ventricular contractile cardiac fiber will actually produce less force. Let's first make sure that we know where less calcium is coming from. Two places. If diltiazem knocks out the L-type calcium channels, there'll be less calcium coming in through the L-type channels, and thus there'll be less calcium to bind to troponin because of that. Also, if there's less calcium coming into the L-type channels, then there's less calcium to cause calcium-induced calcium release from the SR, sarcoplasmic reticulum, so there'll be also less calcium due to that mechanism to bind to troponin. At the end of the day, as I oftentimes say, there'll be less calcium binding to troponin and less myosin and actin interacting. What does that mean inside of the fiber? The ATP demand will be lower. Right? The muscle fiber now has a lower ATP demand because less myosin and actin are interacting, actually consuming ATP. Now, what does the fiber need less of? The fiber needs less oxygen now in order to meet its ATP demand. What diltiazem essentially did is it lowered the ATP demand of this ventricular contractile cardiac fiber. It allowed less myosin and actin to interact by reducing intracellular calcium levels. Thus, the ventricular contractile cardiac fiber is consuming less ATP, and now it needs to make less ATP in order to meet its ATP demand, and thus it doesn't need to receive as much oxygen. What was causing the angina in the first place? Well, the angina was actually happening because these particularly left ventricular contractile fibers, they weren't receiving enough oxygen to actually be able to meet their ATP demands. Well, what diltiazem did is it lowered the ATP demands within those left ventricular contractile cardiac fibers by reducing the amount of calcium inside and thus the amount of myosin and actin interacting. And now those same left ventricular contractile cardiac fibers under the influence of diltiazem are actually receiving enough oxygen to meet their ATP demands because their ATP demands have been lowered. And this, we believe, has some influence over reducing angina. We know that if you give people diltiazem, that the angina is reduced. And this, we believe, has something to do with it. Now, there's much more to this. This is where I don't want to just keep going on and on and on, but if you knock out L-type calcium channels, what you're also going to do is it's going to lower heart rate. Okay? And this is where things, mechanistically get complicated because it's not even entirely clear how it accomplishes this. It probably makes if you knock out L-type calcium channels, you influence the L-type calcium channels. Basically, the idea would be inside of like the SA node fibers. Okay. Maybe -50 isn't sufficient to actually get to threshold. You might need to get all the way to like -45 for enough L-type calcium channels for to actually hit threshold, and thus the SA node fibers would generate less action potentials per minute. But the thing is, in everybody that takes it, diltiazem doesn't actually lower everybody's heart rate, and theoretically, it actually shouldn't lower your heart rate unless it does what I just explained that it does, and that's not entirely clear. Because just because you knock out some L-type calcium channels, what gets the SA node fibers to threshold? Funny channels and T-type calcium channels, which we don't think diltiazem has really any influence of. Maybe perhaps it has an effect on T-type calcium channels, and that might assist. Maybe it knocks some of them out, and that helps decrease, heart rate, because if you knock out T-type calcium channels, then it takes longer. It would take longer to get to threshold. That would make more sense, but again, it's the evidence isn't completely clear that diltiazem binds to T-type calcium channels. Definitely binds to L-type calcium channels. And if you just knock out L-type calcium channels and have no influence over the F-type and the T-type F-type channels being voltage-gated sodium channels and T-type channels being the transient type calcium channels, if diltiazem has no influence over them, then how long it takes you to get to threshold wouldn't be changed by diltiazem at all, and heart rate would stay exactly the same. And that does happen in some people, but not in everybody. So its effects on heart rate, the mechanism actually behind it, if it, when it does happen, exactly what's driving it isn't perfectly clear. Now, what it definitely does do is slow the conduction velocity of action potentials within cardiac fibers. So like within the AV node fibers, if you knock out L-type calcium channels, and this is true for SA node fibers and conduction fibers and all the others, if you knock out L-type calcium channels, the conduction velocity through those fibers is reduced. So there's a longer delay between when the atria and the ventricles contract. What important effect that would have, again, you could, it's debated. There's all sorts of different theories about how that could potentially be beneficial that we really don't have time to get into, but it definitely happens, that is for sure, with regard to conduction velocities. Now, the other really important thing that calcium channel blockers do is they have a direct influence over smooth muscle, which is the next thing that we're going to talk about actually in this class. They cause smooth muscle to relax, and thus they cause vasodilation, which is really important, obviously, for those coronary arteries. Because if you can dilate them, you can get more blood through them. Okay, I'm going to save that for when we get to smooth muscle next year. Okay, there's tons of different calcium channel blocking drugs. And my hope is, I've gone through one of them. This is a really common one. My hope is that no matter which one is brought to your attention, because of all these different things that we've talked about, theoretically it makes sense as to how that specific calcium channel blocker is accomplishing what it's supposed to be accomplishing. And as you'll find out, many drugs, including L-type calcium channels, L-type calcium channel blockers, there's not 100% consensus over exactly how they accomplish what they accomplish. We just know that they have the desired effect that we want, and they don't necessarily kill people, so they get approved. And with that, we will move on.